We are a very large system, like many of you in the room here today. What makes us uniquely different is we have 2,500 employed physicians, along with 8,000 voluntary physicians that we're responsible for. So when you think about the magnitude or the responsibility around trying to get our hands around physician leadership development, it was certainly a pretty daunting task, but we'll talk a little bit about how we got there and what we did. One of the things that clearly we all are faced with today is sort of where the industry's going, right? So we all know we have to change. We all know that if we don't change, we die. I actually had a slide up here, but there were certain rules around only having 10 slides, so I pulled a lot of the slides out. And the slide really depicted companies like Circuit City, right? So what made them sort of go by the wayside? When you take a look at some of the bookstores today, take a look at what happened to Sears and what it was and what it is today. And you start to see the same thing happening in healthcare. We actually, in the New York City area, we had over 10 hospitals, over 20 hospitals that closed over a 10-year period. That's an awful large group, and I think it was over 5,000 beds in total. One of the things here I want to highlight is we absolutely are facing a changing landscape. And the question will be, who survives, right? So there was an email I received today. I leaned over to Jeremy and I said, Jeremy, can you believe this? Xerox is getting into the healthcare exchange business. So our competition is not what used to be, right? It used to be the other hospital down the block or the other physician practice group that we'd be competing with. But Xerox is actually getting into the healthcare exchange business. We're not sure what it's going to look like, but very interesting that there are a lot of other individuals jumping into the healthcare space today. I'm not going to read all of these, but you clearly start to see us focusing more on the patient being the consumer, right? So keeping our patients healthy, being transparent, and when you take a look at what we have to change, not just us as a health system, but I think everyone in this room, is pretty daunting. One of the big things that we absolutely have to focus on has to be this taking an incredible risk, right? It's sort of this chasm that we have to get comfortable with. If we're not comfortable with risk, and we're not comfortable with change, I think there's not much to say other than I don't think you're going to survive, or we're going to survive. The risk in crossing this chasm is tremendous. Tremendous in the sense that if we don't get it right, we might not be around, right? We're a big system, but we're not the biggest by any means, and we're not the smallest, but it doesn't mean that we can't get gobbled up or our competition gets a lot smarter, more efficient, more effective, and targets the patients differently. So we really have to pay attention to that. This is clearly, all it takes is one wrong decision, one wrong move, and it could certainly be deadly for us. We as an organization, probably about 7-8 years ago, started to really get focused on creating sort of this alignment within the organization. We really wanted our senior leadership to focus on 3 major goals, and we have others: patient experience, quality, and financial performance. And that had been our focus for quite some time. We initially, when we went through this exercise many years ago, it was a room full of leadership at the C-suite, and we asked them to list all the things, again, going back to Henry Ford, who was up here earlier, and using the Baldrige criteria to help them align. We did the same thing. We looked at Category 1, tell us what's important, what's the leadership involvement, and they listed a whole host of things. And then Category 7, what do you measure? And of course, in healthcare, we measure everything. And when we brought it together, there was this huge misalignment. So we knew we had a lot of work to do early on in creating transparency, scorecards, and we, as a result of that, we created a dashboard. Most, if not all of our workforce, even when they start first day, are sort of exposed to this and are very comfortable letting you know what the goals of the organization are. Back in 2002, Michael also had a vision. He actually asked Kathy Gallo to help him create the Center for Learning and Innovation, which is our CLI that we refer to. Within that, there are a lot of different institutes within that organization. We just recently, not too long ago, added the Physician Leadership Institute. Under that, we built the Physician High Potential Program. We have a high potential program that we focused mostly on administrators. We had a couple of physicians that were part of that high potential program early on. And most of the reason we focused on high potentials on the administrative side a couple of years ago when we started to look at this was really around succession planning and looking at where we had some weaknesses and what we needed to focus on. And we really needed, ultimately, a physician champion. And Jeremy's going to talk a little bit about his role and how effective he and his team was in sort of bridging the physician leadership development program with everything else that we do and really tying it to the mission. One of the things that we absolutely have to pay attention to is what are the skills needed for tomorrow's leader? Right? What are the skills needed? I think oftentimes you think, well, I have good leaders. But right now I got to tell you, if most of you that don't have an insurance company yet or an insurance product or haven't partnered with somebody that you're going to be selling some sort of insurance product, you're going to need somebody to run that. Who in your organization has ever run an insurance company before? Right? So we're looking for talent. And when we're looking for talent, we're competing with the insurance companies. So the skills or the skill sets that we're going to need for the future, also the ability to adapt, right? So many years ago, 4 or 5 years ago, we learned early on that you can't necessarily take a hospital administrator who has been highly successful, generates lots of revenue, great quality, patient outcomes, all of that stuff, and then we opened up a brand new ambulatory center and be able to move somebody who's run a hospital, 4 walls, this is all I know, and then go ask them to run an ambulatory site or ambulatory business. Very different business. So what we're saying is that the skills aren't necessarily, not that they're not transferable, and in most cases they are, it's just you have to give them, you have to expose them to the right situations. You need to think about what does your leadership development look like. So being able to give them stretch assignments, things like that. When you take a look at this grid, you don't see any mention of patients because our evolution is changing so rapidly. We have to think that, or start to use terms like consumerism, right? What is the consumers that are out there? Most of the folks that we're going to be paying attention to are the individuals that never become patients, right? We talk about ACOs. You heard about it this morning. Our keynote speaker talked about what the vision would look like, being a futurist. This, I think, starts to at least direct us and focus on the leadership skills that we have to pay attention to. One of the things in our organization, and I have to say, I was going to say we as an organization tend to steal best practices. Jeremy told me to use the word leverage, so we leverage best practices. This was actually, Banner Health System had actually used this model, which was really to keep it simple. So I leveraged this from Banner. And the bottom line really is effective talent management. You get engaged employees, satisfied customer and or patient, strategy execution, which gives you business results, right? Keeping it very, very simple. And that's sort of how we built everything we do that we build. One of the things that clearly, our high potential, and we use this for the administrative high potential program, we actually, again, leveraged from DDI. So I think Henry Ford's not inviting me back anymore because I leveraged a lot. But DDI had a great model, right? So we focused on emerging leaders, team leaders, operational leaders, and strategic leaders. So when we think of our high potentials, we're not just focused on the operational leaders that are ready for that strategic leadership role. We're looking at the emerging leaders who have the fire in their belly, team leaders who ran small group or small teams, operational leaders, and then strategic leaders. This has really been an incredible success story for us. We have now about 500 high potentials that have gone through our program. We've had about 80% promotion rate, promotion and or change jobs of those 500 individuals within our institution, and we have over 96% retention rate of those high potentials that went through that program. So we then replicated that for the physician high potential. So that's kind of what we're doing. We're into this about a year and a half, and I'm going to let Jeremy tell you how we did that.
Great, thank you very much, Joe. So just to back up a little bit onto the Center for Learning and Innovation, for those of you who aren't familiar with it, just to give you a sense of the scale of the operation. A CLI, in concert with HR, devotes about 30,000 hours a year to training. We touch over 10,000 employees a year through some form of development. And that was built into when Mike Dowling became the CEO. That was his core belief, was that healthcare is changing too rapidly to not have a very capable infrastructure to constantly adapt to the workforce. And so what we're going to talk about now with regard to physicians is built on a framework that has existed for about 10 years and has been constantly tweaked and refined over that time. Although this portion of the development program has some unique characteristics given the folks that we're trying to train. Most people think about docs and they have an image in their mind. And it looks something like this.
Here's my great-grandfather. He's the first cat herder in our family.
Herding cats. Don't let anybody tell you it's easy.
Anybody can herd cattle. Holding together 10,000 half-wild short hairs, well, that's another thing altogether.
Being a cat herder is probably about the toughest thing I think I've ever done.
I got this one this morning, right here, and if you look at his face, it's just ripped to shreds, you know?
You see the movies, you hear the stories, I'm living a dream. Not everyone can do what we do.
I wouldn't do nothing else.
It ain't an easy job, but when you bring a herd into town and you ain't lost a one of them, ain't a feeling like it in the world.
Well, you get the idea. How many of you have seen that before? It's pretty popular out there. So this idea of herding cats, whenever we talk about physicians, we talk about, this image of a group of people that just don't want to be led. And we have to change our belief system about doctors if we're going to be able to create an army of physician leaders who can help the organization go where it needs to go. And that was a big part of our work, was really going around and looking at other health systems and stealing the best ideas that we could find from them. And one of the things we learned was that, from a lot of folks who have been doing this for a while, is there's certain things that work and there's certain things that don't. What doesn't work? The mini MBA doesn't work. Don't just stick them in a classroom for a few days and try to teach them a lot of business skills and expect that they're going to come out capable of leading the organization differently or partnering with the other leaders in the organization differently. And so we put a lot of thought and a lot of effort into designing something that we thought would get us where we need to go. Well, where do we need to go? We needed to go from a series of more transactional skills to really transformational skills. If we had to boil this down into one skill set, it would be around influence. That's clearly the most important skill that physician leaders need to have, because doctors don't like to be led in a traditional way. They don't like to be told what to do, but they can be influenced greatly by peers who they respect and they view as credible. And they can be influenced by peers who role model the right set of behaviors: collaboration, teamwork, listening, aspirational goals and vision setting, those kinds of things. And that does need to be built on things like some business skill and clinical leadership education, care coordination, and the like. But it really ultimately comes down to influence. So how do you build a program that trains people to influence and lead? We have a pretty rigorous selection process for this program. Folks have to have a demonstrated ability to drive change. That tends to be the best predictor of future ability. And they have to be seen as a natural influencer in the environment that they're in already. It's very hard to teach somebody to become an influencer if they don't have a seed of that already. So that's really what we highlight. And everybody in their chain of command has to agree that they're worth the investment and that they're going to create the time and space for them to be successful. Their executive director, their medical director, and their department chair all need to sign off. This is the curriculum in one slide, and it doesn't fully do it justice. There are some classes that are small group and highly interactive case-based learning environments with faculty from around the organization, and those have been very, very highly rated. But they're only one small component of this. We have brought in external coaching. We use an external coaching firm, Lee Hecht Harrison, again, to deal with the confidentiality issues and also to help the physicians understand that what they're struggling with, the issues are not necessarily unique to healthcare. They're organizational dynamics issues. And there's a lot we can learn from folks who have a lot of experience with that. So that's been very valuable. We do one-on-one coaching as well as group coaching with those coaches. We also expose the physicians to a lot of time with health system leaders and to peers. And the idea is to really let them hear from Mike Dowling and Larry Smith, our dean, what the vision of the organization is and what we're struggling with, the problems we're trying to solve, so that they can get on board with helping us solve them. And we spend a lot of time also giving them opportunities to participate in external electives, coming to meetings like this or going to Harvard School of Public Health. We were given the ability to really spare no expense with regard to this because it's that important to us. So if we want to send folks to Dartmouth to get a master's in improvement science, they go. If we want to send them to another health system and do an exchange program, which we'll be doing in year 2, with some of the folks in this room and some of those organizations, we can send them, to spend a month with a C-suite team at a Henry Ford or another health system. We're also investing a lot more energy in the roles of mentors and sponsors. We think there are 3 key roles. There's the mentor, which is an informal relationship with somebody you don't directly report to, who's in the organization. Your sponsor, who is somebody you report to, or somebody who that person reports to, who needs to take responsibility for your development and make sure you have the time to commit to this, and the external coach. Each of those roles is distinct and has an important role to play. And like I said, a lot of time with their peers. We're developing a cohort of physician leaders who have relationships with each other and can reach across the organization. We're very, very broad. As Joe mentioned, we have 10,000 physicians, 16 hospitals, and over 400 ambulatory sites. So, we need the folks who run these entities and work in these entities to have relationships with each other so that they can come together to solve problems without waiting for us to task them to do it. And that's where a lot of the energy is put into the program as well. We launched it in 2011, in June of 2011. We have 48 participants in the program. A handful we've asked to withdraw because either they didn't have the will and interest to do it, or something happened in their particular situation that made it impossible for them to participate. A couple of folks got promoted into jobs that they really needed to focus on, and we gave them the ability to step out of the program, focus on learning their new job, and then come back into it at a future time. Every year we'll be enrolling another 25 physicians, and it's a 2-year process that they're in the program. And once they're out of the program, we'll continue to have events to bring them together as long as they're in the organization and continue to develop them. This is a list of the expected outcomes. We don't have measurement yet, it's too early. We did bring the leadership of the system together recently at the 1-year mark, and we reviewed every candidate in the program. Where are they? Where are they in their development? Where do we see them going? What do they need? Do they need additional coaching? Do they need additional stretch assignments? What teams do we need to embed them in next year so that they can continue to grow? And that's an important part of the program as well. We wanted to spend the last few minutes introducing you to some of the participants and let you hear, because we don't have hard outcomes yet to share with you, let you hear from them what the experience is like and what we believe they're getting out of it, and what they believe they're getting out of it.
If we're going to transform care, physicians need to be engaged in the process.
And take these challenging times of medicine we ever faced in a different direction.
So that patients can experience the best possible care.
The program gave me an opportunity to take time away from my busy schedule to reflect on things that we ordinarily don't have time to do.
Getting a broader view of how the organization works.
To learn the business of medicine, the operational side of medicine.
strategy, organizational behavior.
I've learned about emotional intelligence. I've learned about how to build a team.
It was an acknowledgement for me of the fact that no man can do this himself, and that I needed to do a better job learning how to listen rather than just speak.
How to grow as a leader and as a physician leader, which is something that we just don't learn at all in medical school.
We're very well schooled in pathophysiology, anatomy, pharmacology, etc. We really have no training in leadership or the ability to guide other folks. This program offers those components.
Where we've been very good throughout our career focusing on the clinical care that's delivered, this program kind of brings us up to speed on where leaders need to be effective in this environment. And that's, I think, the most critical thing that this program offers.
What I learned from the High Potentials program was that I actually have some kind of untapped potential and untapped talents.
There is a blind spot everyone carries, where you don't know you got it, but somebody needs to tell you, either the mentor or the coach or the leader of the organization. That's where the potential come out.
It's given me a voice, that I know that leadership at different levels are willing to listen to my insights and ideas, and at least they're willing to listen. Maybe my ideas are not always the right ideas, but they're willing to listen, and they value those opinions and those insights.
And to use the opportunities that were presented to me to help transform healthcare.
The program certainly has given me the tools to now go ahead and affect change.
We're all passionate about what we do, but I think it's nice to be with maybe like-minded individuals who want to make things better, who are striving to be better than what they are now.
The High Potential program has really been a phenomenal opportunity. We've had a chance to meet with most of the senior leadership of the health system.
Not only to see and understand their vision, but for them to really see on a personal level how we can contribute to that vision.
Of all of the components, the most important one to me has probably been the executive coaching sessions.
Beginning with the 180 feedback assessment.
The opportunity to interact with your colleagues in small groups and build relationships across the system.
You get a more, up close and upfront understanding of the direction that the institution is going in.
I wish I had this opportunity 20 years ago, because I think it would have really made a big difference in how I practiced, what I did, and where my career was.
Working with my team in a task force project has allowed me to improve patient care.
Our service line instituted a program to promote patient safety, specifically around lowering radiation dose during imaging procedures. Going through the program while launching this large initiative across the health system, we got it done, and it's in the process of being operationalized. And I think this has been one of the most gratifying professional experiences of my life.
So much more empowered. It's been an eye-opening experience for me.
It really teaches you how to not only lead change and lead improvement, but lead it in a way that's sustainable and in a way that involves everybody from the front line through the hospital administration.
The program reinforces the core culture that exists at Shore-LIJ, which is one of keeping the patient front and center.
Physicians must play a major role in shaping the future of healthcare in general, and particularly for the North Shore-LIJ health system.
I highly recommend it. I mean, it's priceless.
Thank you very much.